All right, now, ladies and gentlemen, continuing this conversation, we explore the balance between innovation and affordability in modern healthcare. Our next speaker, Mr. Sivaram Rajagopalan, the CEO and Principal Consultant of Shiva Consultant LLP, will share his insight in a fireside session that is entitled, "Is Innovation the Key to Accessible and Affordable Healthcare?" So, ladies and gentlemen, please help me in welcoming Mr. Sivaram Rajagopalan.
Hi, good afternoon, everybody. I hope all of you had an enjoyable day so far today. Thank you very much for having me. Particularly, I'd like to thank both Mosti as well as Maranti for inviting me over here to share some of my experiences and such. Before I get started, can I ask from the audience out here, how many of you are actually from the healthcare sector? Interesting. A few hands only, but let me tell you that you are all from the healthcare sector. You're all potential patients, or if you're fortunate enough, escape becoming a patient, but be healthy, right? So a lot of what I'm going to talk about today will nudge us in that direction. So what I'd like to start with is essentially talk about the topic of innovation from the perspective of a primarily one particular startup that I do a lot of advisory work with, doing some fantastic work at the moment in India. I will also mention other technologies that I feel have a significant impact in this accessibility innovation space. And I would really like to open up to all of you all to see where and how we can collaborate better to take some of these ideas, some of these systems, processes, technologies further forward to serve the populations we are all from. As I get started on the subject, let me say a few words about myself. So, as kindly introduced, I'm actually a strategic consultant. I work with multiple startups from around the world. I'm originally a Malaysian, for your benefit. However, I have lived most of my life outside the country, primarily in Singapore. I have an engineering background from Australia. Currently, however, my second stint living in India. Fascinating, eye-opening, at the same time challenging market to work with. Not only is it large, there's a lot of chaos in countries like India. However, a lot of interesting challenges with interesting solutions, again, which I'll present a little bit later. So as I mentioned, I come from a medical technology background. I've been in healthcare space for almost 40 years now. These are some of the companies I've been part of. Hewlett-Packard's medical group. I used to head the Asia-Pacific business out of Singapore in various domains, patient monitoring, clinical information systems, resuscitation, and so on and so forth. Similarly, with Philips Healthcare, I headed the business out of Australasia for a number of years based in Sydney. And lastly, Laerdal Medical. So these are all multinational companies. Laerdal, I headed the business in India. Laerdal is in medical simulation and training and education. So I have strong interest in the areas of clinical technology bridging. How does clinical technologies and the clinical applications work together? How do we make it something that is understandable by both parties? Technologists need to understand the clinical space better. At the same time, clinicians need to understand how and what technology can be utilized for. And there are many gaps when I look at the past as well as look at the current ecosystem where these bridges have not been done so well. And it's very difficult to move forward and build upon these structures when the foundations aren't so solid. So that's an area I'm particularly interested in. Fortunately, because I ran the Asia-Pacific business in HP, I've had a lot of exposure to markets, whether down south in Australia, all the way up to Japan, or the other side, Pakistan and India and so on. So I've seen many different systems, met with many different technology and technologists out there. But the interesting thing is at a fundamental level, we're all trying to solve the same problem. So I'm also a big proponent of what I call collaborative innovation, because we need to come together a lot more than we currently do. It's fascinating today to hear from Professor Adiba on the projects they're working on, for example, Project Rose. because I'm going to mention something similar, and hearing from her, I want to reach out and have a deeper conversation about what they are doing in that particular space when it comes to cervical cancer screening. So I think we need to collaborate and learn a lot more from each other and share more. So as I mentioned, I'm currently the CEO of Shiva Consultants. We do consultancy services with mostly startups in the innovation area. And on the left side of the screen, you will see multiple companies there. These happen to be some of them that I advise. I'm primarily going to spend most of my talk talking about a company called iCure. So iCure is an Indian-based organization that's doing some fantastic and wonderful things in their geography. And I hope in time to be able to work with all of you out here to bring some of those benefits and experiences to do the same sort of thing in a place like Malaysia or the rest of Southeast Asia. So before I get started on the specifics, the topic today is innovation, accessibility, affordability. There are many definitions for innovation. I just wanted to take a couple of points about innovation so that we are on the same table when it comes to the topic I'm going to cover. So firstly, it's interesting to understand that innovation is actually a disciplined process. It's not something that suddenly creatively you think and say, oh, I can do this as well. Some of that happens. So creativity is not innovation, but innovation contains creativity. So as part of this kind of a journey, it's very important to learn how to open our eyes to see, to be able to observe systems, observe gaps in the ecosystem. And that's something that is a practiced ability for you to be able to spot these things and hopefully connect the dots in your head. So innovation is not only about a product or technology. Innovation can be around the business model. It can be around the process. India is famous for its process innovation. We can do the same job another person does, but with various other advantages. So this is the term commonly used in India called frugal innovation, which is this idea, can I do the same thing at a significantly lower cost? A lot of this work tends to be process innovation oriented. However, you go to a shop, you won't see very many made in India products beyond cultural products. 70% of Microsoft Word or Excel may be written with Indians, but it's not an Indian technology that's out there. But these are challenges I hope in time we will address. Accessibility. Accessibility and affordability are, in my opinion, two sides of a very similar looking coin. It's very much about the perception, the perspective that you take. Accessibility for somebody in an urban area is vastly different from accessibility to somebody in a rural area. Accessibility to somebody who lives on an island versus accessibility to somebody who happens to be on a plane when a medical incident occurs. All of these pose accessibility problems and challenges. Most of my topic today is going to be talking about accessibility from the perspective of rural, remote communities and how we can impact health and health systems in those spaces. Affordability is also a matter of perspective, as I will share with you later. Something that is inexpensive for somebody may be very expensive for somebody else, and that's a standard way, oh, we should drive prices down, we should make it less expensive. I would say that is partly true, but not entirely true. A lot of things can be done at an affordable cost. And again, when it comes to health and healthcare, health in particular, the foundation of health has to be your nutrition, your sleep, your management of stress. All of these elements don't cost much money at all. We can all do this, whether you live in a small village, whether you live in a mansion. But if you don't do it, then it becomes an affordability issue, if you don't do these things. I also want to take a few minutes and talk about healthcare. Since the topic is about healthcare, the topic is about accessibility and affordability in healthcare, I wanted to distinguish between healthcare and health. Healthcare is actually a set of systems, people, processes that come together to usually solve what we call a health-related problem. If you think about it, and I'm sure a lot of you have, healthcare systems are places you fall into when you lose your health. It is where illness is actually cared for. It is not where you go to get health. You lost health, so you go to healthcare. So when you think about it from those perspectives, you realize that in the big picture, if I want health to improve, it's something I need to do myself before I get hospitalized. After I get hospitalized, I've actually lost some level of that battle. Healthcare is largely, because it's largely illness care, we have to look at health from a perspective of self-care. Healthcare is a means to the end, whereas the end is actually health. We should be calling what I'm going to talk about last mile healthcare. By right, last mile healthcare should be called the first mile of healthcare, because health is what you have when you're at home, when you're with your families, when you're with your communities. When you lose that, you fall into healthcare systems as well. Since health is where you lose your health, where do we get health from? It comes back down to you want to look after yourself, you want to look at and understand wellness, you want to prevent illness from setting in, and when it does, you want to manage that illness when it occurs. But the reality is we need to start somewhere. So a lot of what I'm going to talk about will start from healthcare, but hopefully start inching ourselves towards a health model in the future. So the company I'm going to spend a bit of time giving a lot more detail behind is an organization called iCure. They are based in India. They are based in the city of Calcutta. Unfortunately, iCure CEO could not be here. He's currently in Berlin at another conference speaking about what we call blended finance, how to fund health innovation, health projects, and so on. So I'm here instead as his proxy. But Sujay has an interesting journey, and I do want to share that journey with you, and I'll share that on a short video that I'll play after this. But iCure is a company that has been focusing on rural and remote healthcare services to try and change a set of situations that they were confronted with. So I'll play a short video. I hope it doesn't put you to sleep, but I think it's a very valuable series of lessons about how an individual worked with several people, with a community, and how this community together helped change something in one small spot of India and gradually expanded that. And I'll share a bit more about them after the video as well.
My journey with iCure started with a personal tragedy. Watching my father struggle to even access basic primary healthcare made me realize the huge healthcare gap that we have in India. I knew something had to change, and I wanted to become the catalyst for that change. iCure has been built with a mission to provide affordable, accessible, and quality primary healthcare to the last mile using technology. When we started this journey to really identify, select, and train these community health workers, initially it was definitely tough, but over the period, we were able to really break those barriers.
তোমরা কি ন্যাপকিন ইউজ করো? করো না, কাপড় ইউজ করা ভালো না। এটা ইউজ করবে, ঠিক আছে?
We knew for a country as vast as India with more than 650,000 plus villages, it is impossible to have doctors in each and every village, even in the next 50 or 100 years. So the only way that it was possible is to select, train, and transform these village women as frontline community health workers. When our community health worker visits a person's home, they are able to do three things. First is the community mobilization and awareness.
ইচ্ছা দিদিরা আপনাদেরকে বাড়ি থেকেই পরিষেবা দিচ্ছেন, আপনারা এই পরিষেবা খুব স্বল্প মূল্যে গ্রহণ করতে পারেন।
Second is capturing of vitals and conducting telemedicine.
জ্বর থাকে।
And And the third is providing supply chain products such as sanitary pads, spectacles, and medicines. We are able to capture multiple vitals with zero or minimal human intervention, thereby ensuring the accuracy in terms of the data that we capture. Apart from that, we are able to provide a comprehensive set of services, right from blood pressure to SpO2 and many other additional tests.
আপনার পাওয়ার তো অনেকটা বেড়ে গেছে আপাতত আপনি এটা পড়ুন তারপরে ক্লিনিকে গিয়ে ডাক্তাররা কি পরামর্শ দেন ডাক্তাররা দিবেন
So this is how we are able to provide a comprehensive care right at the patient's doorstep, as well as to our eye care clinics and our partner clinics, and then to the hospitals as a referral, providing a complete continuum of care. iCure has been able to create a collaborative ecosystem wherein we have been partnering with global organizations such as University of Michigan, Oxford, Harvard, Stanford, MIT, IIT Kharagpur, IIT Bombay, Waseda University, Japan, and many others, within one objective that if there is any innovation which is there in any part of the world, how we would be able to bring such innovations to the communities at the fastest possible time. And as iCure is really gearing up to strengthen the primary healthcare not only for India but across the globe, especially in the developing nations, we really want your support in this mission for a better life, for a better world.
I hope that story of iCure tells you something about how a small group of individuals in a small corner of India come together and make a big change. I'll go into a little bit more detail about how iCure has been doing a lot of these things in order to enable innovation and such. First thing I want to tell you about the impact they've had. So far, iCure has screened 36 million people in India. It's a huge number. It's of course larger than the population of Malaysia. But it's fantastic to see how a group of people focused, a group of people who come together, a group of people and multiple organizations who collaborated together made a difference. And the interesting thing is we don't want to stop in what we're doing there. We also want to bring a lot of the experiences and a lot of what we're already working on to help other geographies, other parts of the world do something similar. We've covered so far 11 states, only 6,900 villages out of well over 600,000. So within India itself, we have a long way to go. Out of those 36 million people that we have touched, we've identified over 4 million that needed some more detailed, more active form of medical care and treatment. And we do this through a series of different things, both business model, operational model, but the center of all of these are the people who are part of this organization, both the people from these villages, as well as the people who help these villages plug into the healthcare system to enable access and to ensure it is affordable so that the necessary services can be rendered to them. There's a lot more. I don't want to go into a lot more detail, but multiple specialized areas also have been looked into. It's not only about the general screening, but also about identifying potential to do more focused activity around specific diseases or specific scenarios. And some of these have led to more detailed research projects, and I'll talk about that as well, how the work that they've been doing in delivering care now connects into how we can enhance how research and innovation can be done. So 70%, interestingly enough, of the revenue this company currently generates, this is a social enterprise, but a for-profit social enterprise. A lot of the projects and groups out there end up becoming dependent on grant funding, dependent on somebody providing enough dollars for them to continue to do some work. And once that money runs out, the work stops, the healthcare services disappear. That's a huge challenge globally, especially when it comes to rural and remote healthcare. So part of the innovation is how they flipped this ecosystem and how we went from initially funded through grants, NGOs, companies and businesses, how in time we were able to shift that from a B2B mode into a B2C, where the community sees the value and starts to pay for these services. And these are small amounts. Think of it like an inverse of microfinance. Small amounts of dollars collected by a larger population. Now we are able to do this where this company's revenue, it's a profitable company, 70% comes from the B2C. The rural communities we serve pay for the services. So doesn't that then give you a big question mark about what is affordability? How iCure does this is a series of multiple steps. Foundational to this is what we call the theory of change. It is a perspective and a way to look at what needs to happen in a system in order for us to truly have something that's sustainable and impactful in the long run. Too many projects die very early. It's like a startup, right? A startup survives for as long as they can. Hopefully they make it to market. Most of them, however, well over 90% disappear. This is, however, the same problem we face when we go into rural, remote healthcare. Projects start, projects disappear. Funding starts, funding disappears. But the health issue continuously remains that needs to be addressed. So in order to solve problems like this, you need to think a lot broadly. You can't just think about an innovation or technology in isolation. Multiple elements need to come together to service this. Well, there are a lot I've mentioned there. I'll go specifically into the detail of how the theory of change is being applied in iCure, initially in the Indian ecosystem. So the goal is improved healthcare and well-being of the rural populations that we are trying to serve. So if this is the goal, what are some of the hurdles that are there that prevents us getting to this point? In the Indian ecosystem, there are many. So just to take a sample, one is 80% of our healthcare facilities are in urban areas. There's also a lack of continuity of care. Sorry, it's chopped off there. But there's this challenge of the continuity of care. Just like you have programs and projects that come in, do something, you do a camp, you do some screening for diabetes, you do some hypertension programs. When you go away, what happens to the people? That continuity results in frustration for the people in these markets and a lack of trust in the systems that they are dependent on. So we needed to solve this. How do we solve this inaccessibility issue? How do we solve the issue of out-of-pocket expenses, a lot of waiting around in a hospital or in a clinic, a lot of confusion as to what's the doctor telling me, what am I supposed to do, where do I go next? Confusion even in how our organizations and hospitals are set up, built, and organized. Once you see one clinician, you've got to get to another counter to get something else done. Maybe it's a pharmacy, maybe you got to pay a bill, maybe you got to submit more documents. There is all of this confusion in these ecosystems as well. There's also in a lot of these spaces, especially when you are remote from urban areas where there are less prying eyes, lots of gaps in quality. And all of that ends up with poor impact for these people. And again, comes back down to loss of trust, a lot of frustration. People avoid, live in denial. I have a problem, but I will manage. You continue on until it becomes a bigger and bigger problem. We already do that in urban areas. Most of us go and see a doctor. The doctor says, oh, you have hypertension, or oh, you have kidney problems, oh, you've got liver problems. We think the problem happened to us the moment the doctor told us you have this problem. Most of our medical conditions happened 15, 20 years ago. We just found out. We were not looking for it. In fact, we'd rather not know. The less I know, the happier I feel. So we don't want to know about healthcare issues. So what that results in is a lot of issues that suddenly become bigger and bigger and bigger. That's when affordability becomes a big challenge. That's where accessibility becomes a big challenge. So the way iCure solves this is we establish what we call iCure's own clinics. You might have seen that in the video when I showed it to you early on. We establish these clinics near some of these hubs which are closer into the villages. we established a series of community health workers that we call ICHAs, and I'll talk a bit more about them a bit later. So these are those individuals you saw in the video who are talking to the people who live in the villages, either giving them instructions or doing some test, whether it's a blood pressure or some other kind of test. We have a technology platform that we call WIMS that is utilized to collect the data from all of these people so that there is a health record, bearing in mind that these are not patients. They're not yet patients, at least. We have systems, processes. It's very much about people and community. Without that people and community part, none of these things will work. And of course, the world goes around because of money. We need to figure out how do we fund these things. So financing is a critical component, partly solved by the work that they've been doing in their business model innovations, where we have been able to get the communities to sort of pay for a lot of that services. But we also have a mechanism through which we enable the ecosystem to be established through grant funding and such. I'll talk again about that a little bit more. And all of that ends up reducing the challenges that are faced by these communities, so we move towards improved healthcare. Whether this is quality, whether this is affordability, whether this is awareness and knowledge. So this is the broad model on which ICure has been built on. I'll try to delve a little bit more into some of the details within this. Since this is an innovation conference, I want to spend a bit of time on how we enable and facilitate innovation. So I call this the innovation crucible. Earlier on in the video, we mentioned we work with a lot of partners. These are some of the partners we're working with where they are developing a technology, a product, a model of some kind or other that we believe will add value to our ICure intention to serve the rural communities. So we have conversations, whether it is Stanford, whether it's Harvard, whether it is the IITs in India, Waseda University, and we facilitate evaluation of these technologies by bringing their technologies into our ecosystem. And our ecosystem consists of multiple other players as well. We have investors. We have project partners through whom we deliver some of these services. Some cases, the project partners may be a large NGO. For example, Adani Foundation, that's one of the large Indian companies. They, as part of CSR, may adopt a village or adopt a group of villages. We have research partners. We have, whether these are research organizations from outside the country. Surprisingly, we have more research organizations outside the country interested in solving Indian problems than Indian research organizations solving Indian problems. And I think that same applies here in the rest of Asia. We are dependent on a lot of them doing it because we are not doing it for ourselves. And I'll talk a bit more about that again because I think, as Professor Adiba mentioned, she talked about the biases within the data lakes and data sets we have. The bias for us is most of the data we are building a lot of our plans, a lot of our algorithms are mostly from the West. Are we all exactly so much alike that 100% of a data lake in America applies to our health problems? I know for a fact that is not true. We have to build our own data lakes. So in the business model side of things, what ICure has been doing is, firstly, we start usually on a project in a B2B mode. We have conversations with whether this is the likes of no longer available US aid. We used to fund a lot of projects. Or currently we have a lot of other groups like Nippon Foundation in Japan or other groups that are prepared to fund something that has an impact. We talk to a lot of impact investors, philanthropists from around the region. We talk to a lot of companies who are willing to use some of their CSR dollars to have an impact. And we utilize a lot of these funds to build out the infrastructure. Once I build out the infrastructure, then the operational cost is much lower to manage. So once I've got the infrastructure done, I can then gradually start to shift to a B2C model. And that B2C model allows us to have small amounts of funding that comes into the organization that allows us not only to be sustainable, but this B2C model also is plugged into the fact that we provide employability to the people within the communities we serve. And that's the next important component of the solution. But as I mentioned earlier on, 70% of our revenue now comes from this B2C model. But the key part is this hub and spoke model where we have healthcare community workers who go into the homes rather than waiting for an individual to come and see the doctor when they are sick, where we tend to wait until it's often very late. We go into the homes, have conversations in the homes with the different members of the family. That conversation is enabled by people who are selected from within the village itself. So the core component is this doorstep service by our iCure community health activists. These are individuals that we request a village organization or the heads of the village, please give us names of 2, 3, 4, 5 women. We usually only use women as community health workers. And we then identify who amongst these would be able to help us move this cause further forward. We provide them training, and that training results in these people now coming back into the communities as a trusted friend and partner, but now somebody who's paid to do this, so we now provide them an income means as well. The next component of this model for it to work is we create these clinics that are very asset light. We don't do hugely sophisticated clinics. We do things that help us extend and do tests that are not easy to do in the homes. Also where we are able to say, have pharmaceutical drugs available, eyeglasses available. It becomes a bit of a hub also to help re-equip our community health workers. So we create this ecosystem that works directly with the communities that we are in. Of course, on top of all of this is a need to finance this. So one of the new models we have now started in India is this idea of using digital health cards. So each individual has the option of purchasing a subscription-like model card that provides them a whole slew of services without them having to worry. And very often, these village families, children are living in other parts of the country working. They fund those little amounts so that they can ensure that their parents get looked after. We are starting to have discussions at the moment with insurance partners as well to ensure that the quality and services we are able to offer them is broad enough. I mentioned earlier on the importance of us building data lakes that subscribe to content from our populations. So it's a big part of what we do. The other big difference between healthcare and what we're trying to do in health is healthcare tends to be what we call episodic data. You come in for a problem, the data related to you and that problem are collected, you leave. Next time you come in, it's a different episode, it's a different set of conditions that are picked up, and there are small islands within the data lake within the hospital. But for health to work, we have to look much more broadly. So we are building what at the moment I believe is one of the largest data lakes. Today it is Indian. Hopefully as we go to other markets, we will incorporate other ethnic communities from around the region, including Southeast Asia. Research and insight. A lot of this does require us to look at the problem from different angles and also bring in solutions that make sense to the communities we serve. So a lot of our people have the ground level insight as to the challenges they have. So one of the technologies I'll mention later on is a technology that involves a patch. The patches that are available from the West are simply not suitable for communities out here where it's so hot. The patch comes off after a couple of hours. So we have to design a patch that fits our climate, as an example. So there's a lot of needs to look at what is appropriate for our ecosystem. So we work very closely with multiple research organizations. And of course, with the data lake we have the ability now to analyze and study a lot of these things from a different perspective and hopefully identify new and potentially more innovative ways to solve these challenges. I mentioned one of the key components is what we call the ICHA, the iCure Community Health Activists. So these are women selected from the local villages, nominated by the village elders. It's an employed program. Usually for the first 1 to 3 years, we use the grant funding we have, the B2B model, to fund a lot of this activity. Over the course of time, we will gradually wean them off this mode into almost like a commission structure. Each service that they deliver provides them something back. So gradually we shift this from a B2C, from a B2B into a B2C model. And when we make them, push them into this B2C model where the individuals get paid through the services that they offer. One side, we manage the funding for operations of the organization by the communities we serve, so it becomes more sustainable. On the other side, we have HR workers who previously didn't earn anything. Now we've made them financially a little bit more independent. They see themselves and their roles in the communities very differently. There's a lot of confidence that gets built up as a result of all of this. We have a digital platform that enables them to be scheduled for the services that they need to offer to the communities they serve. The goal that we are trying to reach is where an HR worker can basically keep an eye on approximately 10,000 people. It seems like a large number, but that usually means potentially a 1-month visit to a family of 6 or 7. And because of the numbers of HR workers we have, we can manage this across larger territories and so on. A lot of training is involved, but the training is not as sophisticated as we think it is. We have a tendency to think that this is so complex that you need to have a diploma or degree. Nothing could be further from the truth. It's surprising with today's technology how simple things, just like we can all take a blood pressure measurement at home, these women can do that just as easily. Just as we can prick our finger and check for our glucose level. All of these things can be done by simple folk. The other important component beyond training them is the community awareness and engagement. It's not only about the individuals, it's about trying to move the whole community forward, try to build the trust within that ecosystem. And that's one of the gaps that we find with a lot of these projects is trust is not there. Because organizations come, visit, disappear. Another organization come, visits, disappear. They give this, they give that, then they disappear. Whereas because these are people who are coming from within the community, this becomes a very sustainable, high trust level. And that also therefore enables us to now push harder at these individuals to look after their health. I was very fortunate to visit one of these villages, and it's so interesting that this lady has been avoiding her problems for years. She spoke to a doctor said this, she didn't want to do it. The HR worker, who has become now a family friend, gradually nudged and nudged and nudged and went with her to see the doctor, went with her to get the treatment done, went with her on the follow-ups, so much so that now she's being treated and adherence has picked up significantly because of the relationships these people build. We also use these HR workers as a supply chain logistics. Since they go into the homes, rather than expecting the individual to come somewhere else to pick up something or to get things done, as far as possible. So for example, in the video we showed where a lady was handing out pads. So she might go into a house and discover, oh, that lady doesn't have pads, needs a pad, but she can't leave the house because she's got 6 kids or elder parents and it's too far away to go. So what happens here is at the hub, she enters on her mobile device that this requirement is there. The next time she goes to the hub, a pad will be put into her kit. She comes back to the house, delivers the pad. Either the family has paid for it or that particular program that is running there has paid for it. This becomes the spoke towards the hubs that we have. So the clinic you see here is located in usually about anywhere between 15 to 25 kilometers from these remote areas. So this is where the HRs come to get some training, they get updates, they get their kits replenished. So the kit they carry is a backpack. The backpack is usually less than 3 kilograms. It contains various devices, contains an ECG device, heart rate monitor, BP, glucose device, a weighing scale, some measurements for measuring of height and all that. Simple things, nothing very complicated. And they also carry supplies, medications as have been prescribed by the clinicians. And they use a mobile phone to enable teleconsulting experiences to occur. So once a week, different specialties, clinicians come to these clinics, and if need be, the patient can go there and be seen. The bottom end shows you various specific projects we are working on at the moment for various groups: NCD management, hypertension, maternal care, antenatal, postnatal, and diabetes care. There's many others coming down the pipeline. A lot of the innovations require us to have a foundational technology platform, and this is what we call WIMS. So WIMS consists of a mobile phone, cloud-based solution that enables these HR workers to capture data when they go into the homes. This enables them to identify in a sequential manner, in an easy way for them to capture information about what they need to get for, say, if they're doing a hypertension-related project, it'll ask appropriate questions to that to ensure that it's all covered properly. That information goes into the system, populates the health record of that individual, and if and when needed, a clinical consult can be requested and a telemedical consultation can be enabled. It is also through that mobile phone device that we collect data from the, say, ECG device or the BP device or the glucose device. So all that is integrated via Bluetooth, so there's no extra data entry. The creation of this entry point for these HR workers itself took us 2 years. 2 years of figuring out how we could make a system that is easier to use than pen and paper. It wasn't an easy thing to do. A lot of reiterations and conversations resulted in a huge amount of learning from which the platform was built. The platform also has dashboards and other elements for you to do a lot more management of the overall services. We can see at any one point in time which of our HRs are out there, where they are located, if things need to be followed up that have been fallen off. So all of that is captured within the same technology platform. Some of the other innovations we are working on that involve other spaces of technology we are hoping to bring to market. So I'm mentioning one here is a project we are in discussion currently with Waseda University in Japan. So they are creating a little clip-on that connects to a mobile phone that functions a bit like a slit lens for looking at the eye. And one of the areas we're looking to do is, can we easily have an image taken of the eye in these remote areas that then can be partly analyzed by AI or an ophthalmologist or both, so we can identify which of them need or are likely to having cataract development occurring. Another one we are working on currently is preeclampsia. So this is a condition that is quite dangerous for pregnant women, and it is in the data we have, 35% showed signs of preeclampsia. From this particular data set is Malaysian. Just wanted to show you the problem exists here as well. And of these, over 1/3 are considered severe preeclampsia. So we need a simple, easy technology rather than having them to come all the way to a hospital, healthcare facility. Sometimes can be taking many, many hours, even days, in order to get the testing done, let alone then for results to come back. Here's another one we're working on in India at the moment with the IIT Mumbai, who's created a little device that we hope will enable us to identify sickle cell anemia. I know this is not a big issue in Southeast Asia, particularly in Malaysia, but in India it's a large problem. In Africa, this is a large problem where your blood cells are not round but shaped crescent-like. And it's a condition which 5% of the global population has. So we are exploring a technology with, in this case, IIT Mumbai. We'll do some evaluation. If it works well and it fits the ecosystem, then we look to adoption later on. Hopefully the company will be able to commercialize. But in a similar vein, as you can see, we have this opportunity through our platform to do a lot of evaluation and be a bit of a crucible for how technologies can come to market. Another one, why it's very interesting what Professor Adiba talked about with Project Rose, is in cervical cancer screening. So one of the companies I'm in conversation with is in Biogenes, which is a Malaysian company that has been supported out of Meranti. Very happy to have met them the last time I was in the country and thought they were doing some really interesting things. We are now exploring possibly using the work that they've been doing in cervical cancer, and we'll hopefully start an evaluation model in India along those lines as well. The other component that becomes very critical in anything that's innovation digitally led is the data lakes that we actually need to create. Without data, we cannot make any determination on how we move forward, or we are dependent on some other geography, whether it's the US or Europe telling us this is how you should do it, because we do not know. So although I've got a circle here that talks about all of the different essential public services, every single element here requires some level of data. But unfortunately, in Asia, we have done a very, very poor job of this. We are not collecting enough data, whether for research use or for policy use. We are building a lot of the castles we are building. It's like a sand castle based on somebody else's house modeling. And I think that's dangerous in the long run, especially if you think about precision medicine, which is where we're going to. We are not going to be able to build algorithms and systems that help us understand issues that we face, which is also why a lot of our startups and technology solutions we lose them to foreign markets because they fit the models that they have, not the models that we need. Some of the data we have already worked on is we've done case studies on hypertension, another case study on maternal health care, another one on health financing. This challenge of lack of Asian data is going to become bigger and bigger, especially in an AI world. As again, Professor Adiba mentioned earlier on, this big question mark of the bias in your LLMs and your data lakes, when you have a certain perspective or certain set of data and its applicability to all of us, I don't think we should assume that everything that is done there is exactly all we need. I think we need to wake up to this fact. I know for a fact many clinical algorithms that are based on technologies from the West do miss out on disease conditions that are prevalent in our markets. I'll mention it, another one a bit later. Also the fact that when data is episodic, it suits a healthcare system that's disease focused. If you want health, we need to look at longitudinal data. We need to look at data relative to ourselves in the past. And all of that requires us to think about data very differently. Moving forward, these are other companies that we are in conversation with. One of these companies I'm mentioning here is called Cardiac Design Labs. So it's interesting to note that their first device on the market, and I've got one here. This little thing here is almost equivalent to an ICU patient monitor. It's meant to be provided on a subscription model, so there's no heavy hardware cost, but the quality of the parameters it's picking up is equivalent to an ICU monitor. And the other thing we have done with this is we have built the algorithms based on, in this particular case, the Indian vital signs data. I mentioned earlier on that you can't assume all data is equally applicable to all of our populations. Many years ago when I was part of Hewlett-Packard, we have ECG algorithms on our 12-lead ECG machines. What we started noticing, my doctors used to complain about this, that always your machine will say your patient has a condition called LVH, left ventricular hypertrophy. But when we do further testing, the individual doesn't have it. But your machine frequently calls this wrongly on Asians. And the reason I have come to understand that is because our algorithms are based on the AHA MIT database, which is large white American males. Just the fact that we are physically smaller means the coefficients for measurements need to be different for us. But if we don't have the data, we don't look at the data, we won't know. Here's another company. This is a company creating digital pathology, again for the Asian markets. The product on top has been released. It's an FDA-approved device. It's a digitizing microscope just focusing on blood and urine samples. It's the first of its kind that combines both these in one single device, and it's meant for low volume centers in more remote areas to use. However, they are building a second device, which is a larger one here that you see on the bottom. This is meant to compete with the bigwigs in the world. Today, European and Israeli technology that does something similar starts at about 150,000 US dollars. We are hoping to bring this to the market well under 50,000. When we are ready, I'm hoping early to middle part of next year. Here's an interesting technology that is being developed in Italy, but the disease is not in Italy. The disease is in Asian markets. Asian, Middle Eastern, African markets. It is treat a condition called keratoconus. Keratoconus is where the cornea of the eye becomes very thin, and because it becomes thin, it starts to protrude out, and it has a conical shape. This is a condition where you lose your eyesight. It's typically discovered on individuals between age of 18 and 22 when we see the problem occurring. We don't have a means of reversing it today other than a corneal transplant, which is too expensive, and we don't have enough eyes to transplant them. So here's a company in Italy that is using a material called nitinol. You've all heard of heart stents when you have to get a stent put in the heart. It's made out of a metal called nitinol. Nitinol is a nickel platinum alloy. And the nice thing about this material, nitinol, is it's got what we call shape memory. When you inflate it in the stent, it holds the shape. So similarly, we have created a circular version that can be inserted into the eye, and it helps bring back the shape of the eye. This is in clinical trials. First in-human trials are taking place in Barcelona right now. But in Europe, it takes us 3 to 6 months to find one patient. Right now in India, I can go to almost any large eye hospital and I will see 10 patients a day. But we are not innovating. They are. Again, I want to wake up everybody that we need to start doing a lot of innovation in our own markets. Here's another interesting technology. This company called Zipline is a firm that has done some fantastic work in Rwanda. It is currently the world's largest drone delivery company. They became very famous for delivering blood, delivering pharmaceuticals in a model that became very, very well known out of Africa. But what is interesting about this technology, as much as the technology looks fantastic and does a great job, is actually extremely expensive for us to implement. This is not going to scale to our markets where we need this problem. This is going to be used by the likes of Amazon to deliver your next meal or next book or next toy. That's where it's going to end up. It's not going to help us improve healthcare because it's too expensive for us. There are, however, companies who are making less expensive and better alternatives to this that are out there. But of course, we need to collaborate and engage with them. I bring Biogenes back here. They are a Malaysian company that I was really happy to have met the last time. And I really thank Meranti for supporting last time's MedTech Innovation Conference where I met them. The reason I put them up here is I think they're doing something fantastic with aptomias. I'm not sure whether any of you have heard about what this company does, but this essentially is a synthetic short chain amino acid that can be created using AptCAD, which allows you to design an aptomia. An aptomia is like a key. You can insert this key into a particular molecule or set of bacteria or whatever. And once I insert the key, I can track the key using the bottom device called an AppSense. So basically, I can create a way to test for almost anything. This is not only for medical. One of its famous applications is for testing for rice paddy blight. which is an issue that came out in Malaysia some years ago. That's what it was utilized for. So we are now in discussions with them to use their technology to look at cervical cancer, to look at potentially even preeclampsia and other areas. So I'm really proud, and I wanted to announce in front of all of y'all. I'm working with iCure. We are about to sign an MOU with Biogenes in Malaysia to hopefully help them bring this technology to impact healthcare around the world. I also want to show you something that was very interesting. I just dropped this in last minute into my slides. This is something that came about in 2015. It's called the Jeevan Bindi. It's called a life-saving dot. You've probably seen a lot of Indian women with a colored dot on their forehead. But this is a very interesting idea that came out surprisingly from an advertising company in Singapore. And that dot is actually an iodine patch, because a lot of women, particularly in rural areas, are iodine deficient. Fantastic idea, wonderful. Seems like a simple, beautiful, innovative thing. Project is over. Product is over. Did it work? We don't know. Nobody collected data. No follow-up. We have to think about solutions that are sustainable. We have to find committed partners that we can collaborate with. And of course, we need funding, seed capital of some form or other. But I always want to come back down to, can we solve our problems as best as possible in our own markets before we decide to move to the West? Early on, I showed you a slide like this that talked about how iCure does what it's trying to do. I would like to invite all of you and any organizations here to see whether we can work together. The middle two where iCure's logo is positioned are things we have already. If I want to bring an iCure-like solution to a market like India, I need local clinical partners. I need to have local equivalents of ICHAs. So we need to find people from within your villages. We have to look at funding from various sources, whether this is NGOs from around the world or philanthropists from within the country. So we are always seeking innovative, affordable technologies as well. So technologies that are interesting, that have value, we would love to explore and see where we think it could fit with what we're trying to do. We are trying as hard as we can to make the last mile the first mile. So with that, I thank you all very much. Look forward and invite you to any questions you might have. And hopefully we can find more ways to connect, collaborate, and innovate together. Thank you.
Thank you again, Mr. Siva, for that enlightening session. Unfortunately, we're not going to pick any question for this session. So again, we would like to, one more time, ladies and gentlemen, let's give Mr. Sivaram a huge round of applause. And we'd like to invite Mr. Siva for a very quick photo session with our professional photographers. Thank you again, Mr. Siva. All right, as usual, ladies and gentlemen, before we move forward to our last agenda of the day, we'd love to hear your thoughts on our session. And again, you'll see a QR code that is being displayed on the screen. So again, please take a moment to scan it and share your feedback through our short survey. Thank you.